program on co-occurring eating disorders and addiction, implications for recovery, will be presented by Tiffany Schultz. Tiffany earned her MSW from Wayne State University in 2017 with a focus on mental health and substance use disorders and a particular focus on cognitive behavioral therapy. Since interning at Dawn Farm Sparrow Recovery Center, Tiffany has worked in various positions within Dawn Farm and is currently a Dawn Farm Outpatient Therapist. Her passion for work in the addictions field has been coupled with an interest in eating disorders since the start of her work at Dawn Farm, assisting clients to achieve stable, long-term recovery from both disorders. Please join me in welcoming Tiffany.
Hello. I am Tiffany Schultz. I am super terrified to be here for my first Ed Series presentation, but here I am. I tried to bail like 10 minutes ago and Jess told me I couldn't. So here I am. We're just going to try to have fun for the next hour and a half-ish. Like they said, if you guys have any questions or anything like that, feel free to stop me, raise your hand, whatever. If not, there'll probably be some time at the end for questions as well. I'm definitely going to give you guys my email address and everything at the end too. If there's any questions that I don't know the answer to, you're welcome to email it to me and I will find the answer for you. So yeah, today we are going to try to talk about a lot. We're going to try to talk about eating disorders and their relationships to substance use disorders, key similarities and differences between substance use disorders and eating disorders, and how those differences and similarities can sometimes complicate treatment and early recovery and long-term recovery. And then lastly, we will talk about treatment options and mutual aid groups for clients who experience substance use disorders, eating disorders, or both at the same time. So I'm going to be giving you guys kind of a broad view of things, right? A little bit of information about a lot. So if there's questions or anything like that, feel free to shoot an email to me, or if you need clarification on something, just stop me and I can do my best to answer. I am by no means an eating disorder expert. I do not pretend to be. I just, like Emily said, I gained an interest when I started seeing a lot of clients in my work at Dawn Farm who had co-occurring eating disorders and not really knowing what to do with that, right? Like not knowing if the treatment model that we were using to treat their substance use disorder was going to be effective in treating their eating disorder as well, and what to do when it doesn't. So I started kind of gathering a lot of knowledge and resources and books and talking to people and going to things like this to try to gain as much knowledge as I can. So this is going to be me giving you guys kind of everything, everything that I've got. And I'm up here with my trusty note cards and my slides, which I will be looking at a lot because my brain does this cool thing when I get nervous where I like forget how to speak. So see me looking at those a lot. I'm here with you guys. So recovery is never as linear as we want it to be, right? We want it to be this like steady upward projection of goodness, always progress. But the reality is that this is an extremely accurate portrayal of what recovery actually is, right? All of those squiggly lines, all of those ups and downs, it never looks as pretty as we want it to. We might have a plan for recovery, right? But we're going to have to be flexible. We're going to have to go back to the drawing board a lot probably because the two diseases that we're going to be talking about today, substance use disorders and eating disorders, are complex. They're really complex. They are diseases that affect the brain processes, affect behaviors, and there's no one-size-fits-all treatment for either of them. So the reality is that recovery ends up looking a lot like that left side picture. Well, I guess your guys' right side picture, right? All right. So this quote is from a woman named Robin Cruz who helped write Making Peace with Your Plate. She wrote this book. She is a person in long-term recovery from an eating disorder. And she wrote this book with a clinician who treats eating disorders. It says, "The desire to switch the witch for the bitch was always there. Just because I was making inroads to recovery didn't mean I didn't have a deep desire to numb my feelings. Drinking alcohol often took the place of one of my disordered eating in times when my food was under control. It became the thing I used to numb myself so as to not feel my emotions. So I had to say no to that too. Right, so she's talking about being in really early recovery from her eating disorder and realizing that she's starting to reach for other things, right, namely alcohol, because she was at a point in her early recovery where she hadn't quite learned those new healthier coping skills, but she knew she had to eliminate the eating disorder, unhealthy coping skills that she was using. So when she was kind of left in times where she didn't know what to do, she was reaching for a bottle, right? She was reaching for a drink, and that became just as problematic for her. So when we are talking about substance use disorders and eating disorders, this is a really broad definition of both of those things, right? Substance use disorder being a medical condition where one or more substances leads to a clinically significant impairment, giving you mental, physical, emotional, and behavioral symptoms that cause problems in your life, right? Loss of control, continued use despite negative consequences, cravings, usually tolerance and withdrawal, hazardous use, harmful to the body and to the mind. An eating disorder, and this is a very broad definition, is defined as any abnormal eating habits that negatively affect a person's physical and or mental health. And anxiety, depression, and substance use disorders commonly co-occur with those eating disorders. Substance use disorders, right, there's a wide array of things that we're talking about when we say the word substance use disorder. We could be talking about substance abuse, right, and substance abuse is where a person, their use of legal or illegal substances is usually starting to get hazardous, starting to be harmful, definitely not using for the intended purposes, usually early stage kind of stuff. Or when we talk about substance dependence, this is when a person is chronically or repeatedly using a drink or a drug, so much so that their body adapts to that drug, and without it, I will withdraw. This is common with opiates, benzodiazepines, and alcohol. So where, right, if I'm regularly taking the substance, even if it's prescribed to me and I'm regularly taking it as it's prescribed to me by my doctor, I could still end up becoming physically dependent on that substance. So I can be substance dependent without having full-blown addiction. And when we talk about addiction, we're talking about that disease in the pleasure center of the brain that is characterized by that compulsive use, right, the continued use despite negative consequences, the loss of control, and the presence of cravings usually. Any questions about when we're talking about substance use? Yeah, right, so I can be substance dependent even if I'm taking that medication as my doctor prescribes to me, not a pill more or a pill less, and right, I'll still experience those symptoms of withdrawal. It's when I take that pill the next morning saying, hey, I know it's going to cure this, right, that I might start to go down that road into that full-blown addiction, right, that loss of control, the continued use despite all of those negative consequences, cravings, tolerance, withdrawal, all of that, whole 9 yards. So when we talk about substance use disorders as they co-occur with eating disorders, that's what we mean. Eating disorder diagnoses get a little more complicated sometimes. So these are the current eating disorder diagnoses as they are in the DSM-5, which is the current medical manual for diagnosing psychiatric disorders. So when people talk about eating disorder diagnoses, they could be talking about anorexia nervosa. This is characterized by self-starvation and usually excessive weight loss. And I can be divided into two of those categories, right? I can have the restrictive anorexia, or I can have a binge purge type anorexia. If I have restrictive type, it means I don't eat for long periods of time usually all day, hours at a time, sometimes days at a time. If I have binge purge type anorexia, that means I usually binge eat lots of food, usually large amounts of food. It'll vary how often I'll do that, but then I usually purge, right? I self-induce vomiting to get rid of it. Sometimes this is connected to, weight and body loss, sometimes it isn't. This is one that is probably one of the ones you've heard the most about. Or bulimia nervosa, which is the other one that you guys probably are most familiar with, characterized by that cycle of binging and then some sort of compensatory behavior. Sometimes it's binging and then purging, self-induced vomiting, laxative abuse, excessive exercising, something that will undo the binge that I just did, basically. Mass amounts of foods and then some sort of compensatory behavior. And I can have both of these, right? I can have AN and BN. I can have AN and have both types of AN, right? I can have restrictive and I can have binge purge anorexia. A lot of times, people with this one or more of these diagnoses will kind of float around a little bit. Sometimes they have, one thing, one ritual that they stick to, but sometimes depending on where they're at, even in their eating disorder recovery, they might fall back on some of these old patterns, especially those compensatory behaviors, the excessive exercising, laxative use, amphetamine use, things like that. Binge eating disorder is kind of the flip side of those two. So anorexia and bulimia are disorders really of over-control, right? I have a lot of control over what I put in my body and a lot of control over how I get rid of it. Whereas binge eating disorder is characterized by a loss of control, right? So I have recurrent binge eating episodes without that regular use of a compensatory behavior. So when I start to binge eat, I probably have that loss of control mechanisms where I don't really know how or when to stop, or I don't want to stop. And again, not followed by a compensatory behavior, because then we would be more into that bulimia category. And then we have everything else. So everything that kind of doesn't neatly fit into one of those three categories gets diagnosed with something called OSFED, or Other Specified Feeding or Eating Disorder. And this refers to abnormal eating or feeding without all of the symptoms that need to be diagnosed with one of those previous diagnoses. A lot of times, people present with a lot of different kind of disordered eating behaviors, or seemingly strange eating rituals, and they just don't fit neatly into one of those categories. So they'll diagnose them as this so that they can continue to get treatment for their eating disorder. Because again, if we go back to that eating disorder definition, it is defined by any abnormal eating habit that negatively affects my physical or mental health. So it does not have to fit neatly into one of these three categories. It can be anything like that, and we can call it OSFED. So some myths about eating disorders, because there are kind of a lot of myths or just kind of misconceptions, especially around eating disorders. Namely that most people with anorexia nervosa do not just restrict. There's this kind of, stigma, stereotype we might call it, that if somebody has anorexic, she's a rail thin model who never eats, right? That's just not true. And not all people with anorexia nervosa or any eating disorder are low weight. I don't have to be severely underweight or have a dangerously low BMI to be diagnosed with an eating disorder. And malnourishment can occur at any weight. If I'm denying my body of the nutrients that it needs, I can become malnourished no matter what weight I'm at. Not all people with eating disorders have the goal of weight loss or have an issue with body image. Sometimes it's connected to that, but not always. Which is why I think it's important that we be careful with our words sometimes when we're trying to support somebody with an eating disorder, or maybe we're a clinician working with somebody with an eating disorder. You really want to stay away from things like, well, you don't look like you have an eating disorder, right? Or you look great, you look awesome, you don't need to lose any weight. Like, oh, I'm on this crazy diet right now. Like, we want to stay away from making comments about their appearance and their relationship with food, and we really want to stay away from making comments about our own appearance and our own relationship with food. Because you might be missing the point, really. And there are some other eating disorders that are kind of under that OSFED category, like avoidant restrictive food intake disorder. This limits the type or amount of certain foods. Orthorexia, which is being obsessed with clean eating or restricting certain food types. Or having pica, which is where I eat objects that have no nutritional value. So I can have any of those eating disorders or any eating disorder without having the preoccupation with weight loss or body image. Eating disorders are not a choice, right? Just like substance use disorders are not a choice. They are complex medical and psychiatric illnesses with several biopsychosocial contributing factors, right? They are born in the same way that a lot of substance use disorders are born, and often at an early age. And eating disorders are not women-only diseases, right? A lot of men are affected by these as well. This 2007 study showed that up to 1/3 of all eating disorder sufferers are male. And another study done in 2015 showed that on their campus, transgender men and women and non-binary students were the group that were most likely to have been diagnosed with an eating disorder in the past year. So brings us to, right, the chicken or the egg. Which came first, right? Did I get my eating disorder first and then my substance use disorder came? Did I get the substance use disorder first and then the eating disorder came? It can go either way, right? We know the definition of both of these things, the eating disorders and the substance use disorders, and we know that they co-occur. We know that the age in onset, at least for eating disorders, the age of onset is usually between 8 and 21, so 8 years old, as young as 8 years old and about 21, so somewhere in there in teenage years or adolescence usually. And that the onset for substance use disorders is usually in adolescence as well, or at least the introduction to substance usually happens in adolescence. Sometimes a lot of people with eating disorders will start to use substances to regulate their eating disorder. A lot of people might use stimulants or amphetamines in order to suppress appetite or keep up with an insanely demanding workout regimen. If that's my compensatory behavior, is that excessive exercise. A lot of people with ED might also use opioids or cannabis to regulate their affect, regulate their mood even more, or to combat the restlessness from the amphetamines that they're using to suppress the appetite. So sometimes my substance use might be born out of my eating disorder in that way. And vice versa, right? If my substance use disorder comes first, and maybe I enter treatment for that, and I'm in detox, and then I'm in an inpatient center, and I no longer have my number one coping skill, which was my drink or my drug, and I start to kind of act out in all of these seemingly kind of strange eating ways, right? So maybe I'm overeating, maybe I'm binge eating, maybe I start to restrict, become obsessed with my body, become obsessed with clean eating, or just drinking excessive amounts of caffeine and eating excessive amounts of sugar. But food becomes my new coping mechanism, right? I don't have alcohol or drugs, so I turn to food. And sometimes that's how the eating disorder is born out of that substance use disorder. So it can be difficult, right? If I've got both of these disorders and I have them comorbid, right? I am simultaneously trying to increase the amount of control that I have over my substance use disorder or my impulsive behaviors that bring me to use that substance, right? I need more control over this area of my life. And I'm at the same time trying to train myself to have less control over these rigid eating patterns in my life. So that can be really difficult for people with co-occurring substance use disorders and eating disorders, trying to treat them at the same time, right? I have this program over here which tells me that I'm powerless over drugs and alcohol, and I have a program over here with my ED program telling me that I am powerful over food, that I do, have control over my body and what I eat and things. So, right, like how do I reconcile those two things and how do I find that middle ground? Yeah, right, feeling simultaneously powerful and powerless. All right, so some co-occurring statistics, and I will say, first off, they are kind of depressing, some of them. So, sorry about that. We'll try to pick it up after this. But statistics are often not fun to talk about. Up to 30 million individuals in the US of all genders and ages meet criteria for an eating disorder. Better side of that is about 60% of those people usually find stable long-term full recovery from that eating disorder. Up to 35% of individuals who abuse or are dependent on alcohol or other drugs also meet criteria for an eating disorder. Which is compared to only 3% of the general population, which means that if I already have substance abuse or substance dependence or a substance use disorder, I am 10 times more likely than the general population to develop or already meet criteria for an eating disorder. 35% versus 3%. OSFED is significantly more common in people with substance use disorders. So people with substance use disorders are commonly getting diagnosed with that OSFED because their disordered eating is sometimes secondary, or it just doesn't have all of the pieces that it needs to be anorexia or bulimia or that binge eating disorder. Maybe they're doing kind of a little bit of all of those things, so they can't really fit neatly into one category. So people with substance use disorders are most commonly diagnosed with that OSFED. And eating disorders have the highest mortality rate of any mental illness. It says that every 62 minutes a person dies of their eating disorder. And 40% of bulimia nervosa patients from this study reported self-injuring or some type of addictive behavior in the past year. The highest mortality rate, yes, is among people with anorexia nervosa. But yeah, you can also die from complications related to the bulimia nervosa or the binge eating, because the binge eating disorders is going to give me a lot of the same health complications that sometimes being overweight can give me. And the bulimia nervosa, there is a lot of, depending on what kind of compensatory behaviors that I'm using, right? If I'm taking an extreme amount of laxatives, if I'm forcing myself to vomit a lot, if I'm, a lot of times it depends on what kinds of substances I'm using to do that, what my compensatory behaviors are, how long I've been doing it, and a lot of times just the state of my body and whether I'm malnourished or starving or, or have some other disease that is caused as a direct result of my eating disorder. Lifetime rates for substance use disorders in various eating disorder subgroups. So this means how many people with anorexia nervosa have a substance use disorder? Approximately 27%. 36% for bulimia nervosa, 35% for the binge eating disorder. And women with anorexia nervosa are 19 times more likely to die from their substance use disorder than the general population. Why do you guys think that is? Right. If I'm in full-blown in my anorexia nervosa, I'm actively in my eating disorder, probably malnourishing my body, right? Especially if I'm restricting and then I'm drinking alcohol on top of that or excessively using other drugs on top of that. Yeah, absolutely. Approximately 57% of males with binge eating disorder will also experience a substance use disorder in their lifetime. And individuals who undergo that bariatric surgery are at a higher risk for developing a substance use disorder. For those of you that aren't sure, the bariatric surgery is the one that reduces the size of your stomach, right? So if I am a person who previously was maybe a binge eater, right? Well, now I have this bariatric surgery. My stomach is physically too small for me to actually eat or binge the way that I maybe wanted to in the past or that I would in the past. So I turn to alcohol, right? Or I turn to some other substance, usually within the first few years after recovery from that bariatric surgery. All right, so common personality characteristics of the co-occurring population. So people who are lucky enough to have both of these diseases usually have kind of three hallmarks to their personality. Harm avoidance, right? So being hypersensitive and usually pretty self-conscious. And the common result of that is I need some sort of anxiety management. I need some way to numb out or push away these negative feelings about myself or my anxiety. Self-directedness. Usually people who do connect their values to behaviors and have strong feelings of insecurity or inadequacy. The common result of that is I disconnect from my values, right? I have these values, I have a strong sense of them, and I can connect them to my behaviors, but my substance use disorder or my eating disorder is causing me to act in a way that is against those. So I usually start to feel a disconnect from my values, uncertainty about my future, feeling stuck, right, because I'm not making decisions anymore that are in line with my values. And novelty seeking. So definitely higher among the SUD population, but still seen in the ED population, particularly in people with bulimia nervosa, because of how kind of quickly I get bored or quick with my emotions. It's going to make it so that I have difficulty following rules. I'm always kind of looking for the next big thing, the next thrill, the next trend, the next diet, whatever that might be. So if I am to seek treatment for these things, what I want to address is for that harm avoidance and the need for anxiety management, right? Learning how to urge surf. Learning how to get through like those kinds of unpleasant emotions or unpleasant feelings in my body and kind of surfing it out. Identifying values and developing goals that are in line with them for that self-directed piece. And then having as much autonomy over treatment as possible, right? If I'm a clinician, I need to try to give my client as much say over their treatment as possible. And if I'm the client, I need to be speaking up, right? I need to be making sure that the treatment plan that I'm getting is a treatment plan that I'm agreeing to that I want, right? Because that's going to mean that I probably stay engaged in treatment a lot longer. A big thing with substance use disorder treatment and eating disorder treatment is high dropout rates, right? I start, maybe I bit off more than I could chew, or somebody's recommending that I do something that I'm just not ready for. So I didn't feel like I had a say in it. I don't want to do it. So I turn around, and maybe I come back later, maybe I don't. But having that strong therapeutic alliance first and foremost, and having a place where I can feel safe. That's the biggest, precursor to effective treatment is, do I have a strong therapeutic alliance with my clinician or with my team of people who are treating me, that unconditional positive regard, and do I feel safe where I'm at in treatment? Emotionally safe, physically safe, psychologically safe. So how are these things similar? Well, a lot of ways. ED and SUD both have an increase in behaviors needed for some effect to separate from current reality, right? Usually both of these behaviors, whether it's an ED behavior or an SUD behavior or drug use, I'm using it as some form of escape or solution, right? And I need more of it over time because it stops working as well as it did for me in the beginning, right? Because this is progressive. So eventually I'm going to need to do kind of more and more of whatever the behavior is that's giving me that desired effect to separate from reality. Because the behaviors are largely used to regulate my emotions. With both of these, SUD and ED, coping does not involve social supports, and they have avoidant behaviors with them that perpetuate and intensify those negative emotions and behaviors, right? Why are eating disorders and substance use disorders so isolating? Embarrassment, right? Yeah, these are a lot of things that are done in shame. And the behaviors are just kind of downright shocking for people sometimes. Lots of shame attached to them, lots of guilt attached to them, and then things that I don't usually let other people see. Things that I usually do in private. Onset, usually in the youth for both of these. So there's a need for early intervention, right? And even prevention. Prevention is really important with both of these. Early education, and definitely early intervention, right? Paying attention to those first red flags as a parent or something when you see that, that disordered eating going on in your son or daughter. Same with the substance use, the risky substance use at a young age. Both of these diseases are chronic, progressive, and fatal if left untreated, right? They're chronic, they never go away. There's no easy cure. I can't just walk into a treatment center and walk out a changed person and never have to do anything again. I'm good, I'm cured for either of these diseases. It's just not going to work that way. They're progressive, they both get worse over time, right? The frequency and the intensity of my behaviors or of my drug use is going to escalate. And again, fatal if left untreated. Both of these diseases will end in death if I don't get help, if I don't get into recovery. Stress as a major trigger, trigger for use and trigger for relapse, right? So if I'm out there using or I'm out in active addiction, stress usually is my trigger, any kind of stress. Because I use this as a coping mechanism, right? If I get stressed, I get unwanted emotions and unwanted thoughts, and I don't know how to deal with those. If I don't have something healthy to pull out of my pocket to use, I'm going to go back to what's familiar, usually, right? My eating disorder or my substance use. Social supports are key in long-term recovery maintenance, and both eating disorders and substance use disorders usually require long-term intensive treatment. Because right, like detox is important, initial stabilization is important, weight restoration is important, but those are all very early and very short-term treatments for these diseases, right? If I just go into detox and go out, how long am I going to stay sober for? Probably not very long, right? If I just go into the hospital for weight restoration or something for my eating disorder because I'm malnourished or I'm starving, I need to get back up to a healthy weight. Okay, great, couple weeks in the hospital, I'm good now, I'm leaving, right? I'm gonna go back to eating how I was eating before probably, doing the same unhealthy behaviors that I was doing before. So that long-term intensive treatment is key in that social supports following treatment as well, right? I need long-term engagement, I need support, I need accountability. And the way we do that is usually through some sort of mutual aid group, 12-step group, long-term engagement in outpatient therapy. More similarities. Research suggests that there is a strong genetic component to both of these. When it comes to substance use disorders, it's said that there's somewhere between a 40 and 60% genetic component to it, where with eating disorders, the studies are a little bit more of a wide range. There's not a ton of studies on it, but the ones that do are usually twin studies. And they found mostly a genetic vulnerability in anorexia nervosa and bulimia nervosa. And anywhere, I said it was a wide range, between 28 and 74%. So between 28 and 74% for anorexia, between 28 and 83% for bulimia nervosa, for a genetic vulnerability to that. Lots of studies out there, though, about it that are kind of right all over the place. 28 to 74 is a pretty wide range, but some genetic component. They both have links to certain chemical processes in the brain, dopamine, glutamate, serotonin. They both affect that midbrain pleasure center area in your brain. Both of these disorders have the presence of those cravings, right? I crave to, eat food. If I have binge eating disorder, I crave food possibly in the same way that somebody craves, drugs or alcohol. I crave to, act out on my eating ritual in the same way that I crave to use drugs or alcohol. I have a continued use or engagement in the behavior despite negative consequences. For substance use, that usually looks like, I continue to get arrested, or I continue to overdose, or I continue to have all of these, negative things happen to me, yet I can't stop using this drink or this drug. For eating disorders, it's usually more like I'm having a lot of health issues. I'm having gum disease problems, and the teeth enamel is rotting off my teeth, or I'm terribly underweight, or I'm having all these medical complications from it. My family is angry with me. People are frustrated with me. They don't know what to do. I don't know what to do. I know it's bad or it's unhealthy, but I just keep engaging in those behaviors. Inability to cut back or stop despite those repeated attempts, and sacrifice of other interests. So eventually my work, family, my leisure activities are all going to be affected by one or both of these diseases. And onset and course for both of these are heavily influenced by social pressures, media messages, environmental triggers, the dynamic of the family I grew up in, the level of emotional trauma that I have. All of these things kind of play a factor in onset and course of my disease, particularly when the onset is in youth, right, or in early adolescence, because we're constantly given things like this, right? The media is full, and this took me like a whole 30 seconds on Google to find all of these. I didn't even have to look hard. We're given all sorts of messages. I mean, this is a 17 magazine for like teenage girls, and it's like, look how to get your bikini body, or nothing tastes as good as skinny feels. And alcohol and drugs are advertised in the same way, right? A shot worth taking. That's an Ann Arbor weed maps thing, All of these fad diets, right? Women especially are targeted with all of these get skinny quick or get muscle quick kinds of things. But men too, right? Build a beach body, get a six-pack overnight or something. We're hit with this stuff all the time, especially the kids, right? The people who are on social media all the day, the people who are watching TV all day. I mean, you can't drive down the street without seeing a billboard for a liquor store or, for some sort of fitness something. I can't be in line at a grocery store to check out without seeing all of these like Star Magazine, Us Weekly kinds of things. They're everywhere, right? The media messages are everywhere. Eating disorders are complex. Eating disorders and substance use disorders are complex illnesses. And this is my fancy dopamine brain picture. It's supposed to make me look really smart. Is it working? So dopamine moving from that midbrain area up into that frontal cortex. And if everything is working properly, I should have a bit of a top-down control over that. My frontal cortex says like, hey, let's make some good decisions. My midbrain's like, hey, yeah, you're right. We don't need that right now. In addiction and often in eating disorders, that gets flipped around, right? My midbrain starts to run the show because that's the pleasure center of my brain. So it sees, that next drink or drug as survival. It sees the behaviors that give me dopamine, whether that's my drink or my drug or my eating disorder. It sees that as what's important, So I lose that top-down control, start to have that bottom-up control. The neurotransmitters that play a key role in eating disorders and substance use disorders, number one is dopamine. Dopamine gets a lot of hype because it is released through or it produces pleasure through the reward system of the brain. Serves functions like controlling movement, regulating hormone responses, is important to cognition and emotion. And substances will give the brain much higher dopamine spikes than it was designed to take, really. Other things that give me dopamine spikes would be things like sometimes exercise, food, sex, excitement, comfort, and drugs for the most part, and sometimes food. Glutamate is used in every major excitatory function in the brain, and it helps me regulate learning and memory. And people with an eating disorder who are malnourished, if I'm malnourished, I have lower glutamate levels, which is going to impact my learning and my memory. So early recovery and treatment can be tough. If I come into treatment malnourished and I have those lower glutamate levels, it's going to be really hard for me to get on board with the CBT, DBT, mind shifting stuff you're trying to throw at me, right? I'm like trying to learn all these new tricks, trying to learn all these new coping skills, but the memory and learning part of my brain is not helping me out at all. Serotonin also gets a lot of hype as a neurotransmitter, I guess. Complex function, it plays a role in cognition, reward, memory, things like sleep, sensory perception, controlling emotional states such as anxiety and depression. And sleep disturbance is common among binge eaters who are particularly susceptible to serotonin. So if a bunch of serotonin is released because of my binge eating, I'm probably having trouble sleeping at night. So, important differences that play a role here. So abstinence and relationship to triggers. When I see a client for treatment for a substance use disorder, often some of the things I tell them is, you should probably stop using drugs and alcohol, abstinence. You should probably avoid places where drugs and alcohol are sold, for now at least. And you should probably avoid people who use drugs and alcohol, right? Seems simple enough, abstinence-based treatment approach for substance use disorders. But that doesn't really fit with eating disorders, right? I can't say, I need you to abstain from all food, I need you to stay away from places where food is sold, I need you to stay away from people who use food, because they could trigger you. So it's, the difference there is I have a lot different relationship to my trigger, right? If I'm an alcoholic, I can avoid my trigger completely. If I'm an eating disorder person in recovery, I can't, I have to see my trigger at minimum 3 times a day, right, if I'm going to eat 3 healthy meals a day, and I can't avoid it. So I need to, treatment needs to focus more on how can I develop a new relationship with food? How can I develop a healthy relationship with food? Because I'm not going to be able to abstain from it the same way I abstain from my substance use. Food is part of culture, right? Family, social relationships, difficulty in avoiding those triggers. Physiological dependence versus a psychological learned behavior, right? A lot of times if I am addicted to a drug, right, I'm addicted to, it's got a hold on my body. I have tolerance, I have withdrawal. When I stop using it, I feel it. Not so much with food, right? I don't have a withdrawal necessarily from my eating disorder. It's a psychological learned behavior. So in order to treat that, I've got to find the root of that, right? I've got to find out, what is this behavior doing for me? How did I learn that? What's the root of that? And what healthy coping mechanism is going to give me the same effective feeling that I want? Addiction to product versus addiction to the process or the ritual, right? With substance use, I'm addicted to the alcohol, right? I'm addicted to the heroin, to the, the pills, whatever it is. Whereas a lot of times with the eating disorder, it's an addiction to the whole process, right? And it is a process. If you talk to anybody with a diagnosed eating disorder, especially people with AN or BN, it's, their whole day is usually planned, right? These are disorders of over-control. So I've got a whole process, a whole ritual that I need to do from start to finish. And that is usually what gives me the gratification or the feeling that, I've done it. I've successfully controlled my eating for the day. When really I've been restricting my food intake, or I've been binging and purging. Small difference in stigma, right? Addicts and alcoholics probably get treated differently in the ER than somebody with an eating disorder, right? Just stigma. There's still more stigma attached to being an addict or an alcoholic than there is for being a person with an eating disorder. And because a person with an eating disorder might not present right like anything is wrong. They might look like your neighbor. They might just look like whoever's sitting next to you right now. They also might be extremely low weight. They might look like they really need medical care right now. And so that difference in stigma is significant in somebody getting treatment or staying in treatment for their disorders. And insurance coverage and treatment availability vary greatly as well. Both resources are scarce. Obviously, we know that we could use 1 million more substance use, treatment facilities, but we could use 2 million more eating disorder treatment centers. There's a lot of outpatient options around, a lot of therapeutic options, but to find inpatient treatment for an eating disorder is really difficult, especially if you don't have either the funds to self-pay for it or a really, really, really good insurance plan. Otherwise, you usually get outpatient treatment or IOP or partial hospitalization, which are no doubt good programs, and there are good programs in this city for that. But if my disease has progressed far enough, sometimes it's not going to do it, right? Sometimes I need that inpatient stay. And so for a lot of people, that involves flying all the way to another state and paying, a bunch of money, or hoping that my family can help me pay a bunch of money to get into treatment. Eating disorders can be masked by substance use disorders. Substance use might mask those ED behaviors or be used as part of ED-related rituals, like we talked about using substances to curb my appetite or to, eliminate the effects of me curbing my appetite. As someone enters into abstinence from drugs and alcohol, they might reach for alternative coping mechanisms or behaviors such as food or disordered eating to cope with re-emerging emotions, right? So that's kind of that switch kicking, like Robin Cruz was talking about in that first quote that we shared, right? Now that my food is under control, now my eating disorder or my substance use disorder craps up. Now that my substance use disorder is under control, well, now my eating disorder craps back up. It's like playing whack-a-mole. Disordered eating patterns also often go undetected by an SUD treatment team, right? If that SUD treatment team isn't really well versed in what to look for, they're not going to really know what they're seeing, right? A lot of inpatient facilities don't supervise food consumption very closely, right? Usually there's somebody up there with them, making sure that everything is copacetic, but they're not usually monitoring every single client's, how much they put on their plate, and did that person go back for seconds? Did they go back for thirds? Is that person binge eating? Right? Those aren't usually the things that they're paying a whole lot of attention to during meal times. They're often unsure of what constitutes a red flag, right? Is the person who just came in to detox overeating because they haven't eaten in a week because they've been living homelessly on the streets? Right? Or are they overeating because now they suddenly have an appetite? Are they not eating at all because they don't have an appetite, right? Because they are detoxing or they're going through a bunch of crazy emotions. Maybe they're hoarding food because this was a person who was homeless previously who isn't sure if that food's going to be there for them later, right? It's not all of these behaviors that would sometimes be red flags for an eating disorder specialist. They're not always red flags in the substance use disorder setting. Because also, right, it's not uncommon for us to see clients that come in malnourished, that come in looking like they're underweight or unhealthy, because that's just the state of their body, right? They just haven't been eating healthy, right? They've been out using drugs and alcohol. So it can be tough to figure out as an SUD clinician what to look for. And if I do see something strange, what do I do about it? Because many individuals with eating disorders also become really good at hiding their symptoms. A lot of times they've been doing this for years on end and then got really good at hiding it from mom and dad or spouse or people at work. So unless they want you to, a lot of times you're not going to notice it. And it's even harder to detect at lower levels of SUD care. Right? So if I've got a person coming to me every week for outpatient, it's really hard for me to check in with them about their eating disorder, right? It's hard for me to kind of monitor that unless they're willing to be open and honest with me about it, of course, and keep me in the loop about it. But I don't see them eat meals, right? So I don't know what to look for. And if a client hasn't told me they had an eating disorder, me seeing them for an hour and a half a couple times a week isn't going to let me know one way or the other. So when we do have a red flag, what do I do with it? Or actually, what is a red flag? So this is not an exhaustive list. Leaving the table within 10 minutes of eating a meal. Why is that a red flag? Gotta go purge probably, yeah. Stirring or playing with food rather than eating it. Skipping meals really consistently. Skipping a meal, then overeating. That that should say hoarding food, not just like hoarding anything, but hoarding food specifically. Super rigid eating patterns, right? Like I have to eat this amount of this, or I'm super obsessed with the calories of it maybe, or I'll only eat certain types of foods. That can be indicative of something kind of in that OSFED category, right? Am I extremely restrictive with some types of foods, or avoid certain? Somebody who in substance use disorder treatment is repeatedly expressing concerns about being fat or losing weight, right? They seem kind of obsessed about their body, losing weight, exercise. They want to make those things part of their treatment plan goals, when it really just doesn't seem like that's not what we're doing here, right? We're here to treat your substance use disorder, but this person is kind of repeatedly bringing up things related to their body. And of course, watching for excessive weight gain or weight loss while in treatment, right? That is a big medical red flag. If somebody seems to have lost a significant degree of weight while they're in treatment, that is something that you're going to want to check in with immediately, because that could mean that person needs to leave substance use treatment and go seek treatment for their eating disorder, because they are now medically unsafe to be in a substance use environment. So what to do if somebody sees this? So if I'm a clinician and I notice this in some of my clients, especially in an inpatient facility, don't assume it's an eating disorder, right? Don't really assume it's anything. I'm just documenting, right? I'm just noticing right now. Because people exhibit all sorts of strange behaviors when they first come into substance use disorder treatment. So some funky eating patterns in the first couple of days or weeks might not end up being anything, but it's definitely worth noting. Use it as a gentle red flag. If you're comfortable with this client, if you know this client, and you know that they have a history of eating disorder, then maybe you talk to them about it. Maybe you continue to monitor it, because it doesn't seem like something that's out of hand right now. Again, if you're comfortable with this client and you're noticing more than a few of those red flags, do a 24-hour food recall. See what their last 24 hours looked like. It should give you at least a rough idea of their pattern of eating right now. This one's important. Keep your personal opinions on food and body image to yourself, right? That goes back to the words, right? We want to be really careful in how we talk to somebody that we're trying to support through having an eating disorder. Staying away from opinions about their food or body image, and namely opinions about my own food or body image. And again, if I notice a lot of these red flags and I'm worried and I don't really know what to do, then I need to seek advice from an eating disorder specialist. Or if my client comes to me and says, hey, I have an eating disorder and this is something that I want to address here, I need to have resources. I need to have people that I can call, because again, I myself am not an eating disorder specialist. If I'm working in a primary substance use disorder facility, then I'm probably not an eating disorder specialist. Eating disorder specialty teams are usually comprised of several individuals, right? Therapists, dietitians, nutritionists, doctors. We can't wear all of those hats at once. So if I notice these things enough to be concerned, then I need to contact somebody who's a specialist so that they can help me with level of care. So they can help me decide, hey, is this person safe to stay in inpatient substance use treatment or not? A lot of times, unless there's a significant medical concern or the ED behaviors are hindering their progress in the substance use treatment, then they're usually safe to stay in the substance use treatment until it's done, and hopefully that aftercare plan or that discharge plan is like straight into a PHP or into some sort of eating disorder treatment as a part of that aftercare from the substance use disorder facility. And then follow up, right? If I'm discharging this person from my substance use program, and part of their aftercare plan is getting linked up with an eating disorder therapist, hopefully I have long-term engagement and aftercare with them. When I call them in a few weeks or in a week or whatever, I'm checking in with them on that. Hey, did you call that therapist? Are you doing it? How's it going? Do you want to sign a release so we can talk? Having those open lines of communication so that your SUD treatment team can be on the same wavelength as your ED treatment team. Because we would like them to be the same team, but that doesn't really exist, and we'll get to that soon. So dual recovery. Similar to that first slide that I showed you guys. We want it to look like just get from point A to point B. But it's not always that easy, right? These are chronic conditions where relapse happens with both of these. And I might be playing whack-a-mole for a while. Remember, one crops up and I get the ED under control, and then like my substance use starts going wild, so I get that under control, and my eating disorder gets out of control. So a lot of times I'm switch kicking for a while until I find the program that's right for me. So eating disorder treatment disparity. These beds, the big one, the big purple one, 2,913, almost 3,000 beds. That is acute care hospital beds per 1 million US residents. So per 1 million people, we've got almost 3,000 beds for you if you have some sort of acute care illness that you need, right? I need to go into the hospital for like 1 to 5 days or something. I've got a lot of beds for you. We've got them, come on down. Per 1 million people with a psychiatric disorder, so 1 million people with a psychiatric disorder, we've got 1,400 beds for those people, right? So hopefully only 1,400 people out of that, 1 million people with a psych disorder need to be hospitalized right now. Which, yeah, I mean, they experience here at St. Joe's, at U of M, where the psych beds get full, right? And they've got to start calling around to other hospitals to figure out, this person needs to be hospitalized. Where can we put them? That is per 1 million people with an eating disorder. Remember, there are 30 million people, approximately, with eating disorders. We've got 224 inpatient beds for you, right? These are for the people who need to be medically monitored, usually in some type of hospital setting. But yeah, per 1 million people, hopefully only 224 or so of you need to be hospitalized, I guess, right? Which is why it's so tough to find inpatient, quality, long-term eating disorder care, right? Because there's just not enough beds to go around. They just don't exist. And to find a co-occurring bed, right, to find that perfect program that we want to treat the substance use disorder and the eating disorder, if I have both, that's a hunt and a half in itself too. So these are the different kinds of ways that I can go about treating both my substance use disorder and my eating disorder. I can do sequential treatment, which is probably the most common way I would think of that we do it, where I have to focus on the most acute or severe disorder first, right? So which one has me like down and out right now, right? Is my substance use disorder so bad right now that I'm going to drink myself to death or have an overdose, or is it deadly enough right now that I really need to focus on that before I can do ED treatment? Or is my eating disorder, right? Am I malnourished? Am I low weight? Do I need medical intervention before I can do any other kinds of treatment? So I do one treatment first, right? Treatment is delivered by separate providers at separate locations, usually at different times. So this month I do this, I get discharged, and the next month I go here, and then, so different providers, different times. I can do parallel treatment, which is where both disorders are addressed at the same time, but with different providers, usually at different locations. So this is, I would say, a little bit better than the sequential treatment, because I'm still, I'm treating them both at the same time. But there's a risk with that too, right? Like if I'm getting just two wildly different treatment approaches for my ED and for my SUD, that can be really hard for me to try to grapple with as the person getting all of this treatment. And maybe the environment at each place is not conducive to my other disorder, right? Like if while I'm at my substance use disorder treatment facility, there's a bunch of food or something at my disposal all of the time, and binge eating is something that I struggle with, or if while I'm at my eating disorder treatment, there's some sort of trigger for my substance use disorder, I'm going to really struggle doing both of those at the same time. Dual diagnosis treatment. This is the gold standard. This is what we want. Ideally, everybody with a co-occurring eating disorder and substance use disorder would get this, right? Both disorders treated simultaneously within the same facility by an integrated treatment team. So I've got all my doctors and teams and clinicians and therapists under one roof. I don't got to leave the building to go to another treatment or something, and I can do it at the same time, and my whole team is together and knows what we're doing. That would be ideal, right? But very, very, very few and far between, and currently there is actually no agreed upon evidence-based integrated treatment model for such treatment. So the best we can do is kind of trying to hodgepodge something together between your treatment providers, right? It's trying to tell my substance use team, hey, I really need eating disorder treatment, and telling my eating disorder team that, and then signing releases and getting people on the phone and getting people engaged with each other so that we can work together as much as possible. Because again, that risk is always going to be that while I'm in treatment for my substance use disorder, my eating disorder crops up. And then I enter ED treatment because it got so bad that I had to leave my substance use treatment facility to do so. And now I'm there, and now I'm back to having my substance use pop back up. You know, what would be the ideal treatment model, right? Is that the question? The ideal treatment model would be, I've got, you know, multiple kind of models of care, like, and we're going to get into kind of different behavioral models of treatment here in a second, but I've got multiple clinicians well-versed in different behavioral models of care. I've got, you know, medical monitoring in case my ED client needs that, or in case my substance use disorder client needs that, right, if I need to be medically detoxed or something. Yeah, I've got nutritional care, I've got dietitians, I've got psychoeducation, I've got, you know, social supports, right, that 12-step meeting integration or that mutual aid group, getting people introduced to people in the community who have done it, who are going through it with them, and can continue to go through that with them. And yeah, being treated simultaneously under the same roof in the same city at the same time. Because this gold model doesn't exist, right, because this wonderful, mystical, in a faraway land, awesome, great treatment center doesn't really exist right now, or at least not, probably not within our price range, then yeah, the existing treatment centers that are treating these people who know that we're having co-occurring you know, clients, we need to step it up, right, by way of what kinds of foods are we offering for people, and do I have other people at my fingertips, those nutritionists, those dietitians, those ED specialists that I can call on when I need to. And do I have kind of something in place for all of my clinicians to be able to do that? So for dual diagnosis, right, it's obviously ideal, but difficult because of a lot of the reasons that she just explained to us, really. Most addiction-focused treatment centers are not equipped to address eating disorders. There's no mealtime support. There's little access to ED specialists, no access to intensive medical monitoring. And vice versa, the ED-focused treatment centers are not treating that addiction, right? They're saying, let's treat what you're here for right now. You can go to some 12-step meetings afterwards and you know, worry about that addiction piece, but right now we got to treat the eating disorder. Nonetheless, research shows that some sort of integrated treatment model is essential to stable long-term recovery from both disorders. But sometimes I need that medical intervention for my ED first before I'm able to enter into a concurrent treatment or substance use treatment, or vice versa. If I want to enter eating disorder treatment, sometimes I need to be detoxed and stabilized first. So sometimes we have to use some of that sequential treatment when there's major medical issues going on. And watching for those major medical issues, right? Refeeding syndrome, that happens when somebody is having food reintroduced to their body and their internal organs actually go into shock because they are not used to that much coming in at that time. Integrated treatment and recovery. So, you know, if I'm to try to be the best treatment provider I can be, even if I am primarily trained in treating substance use disorders, things that I can do or beliefs that I can have to help my co-occurring client have the best chance possible at long-term recovery is hope, right? Hope is critical with both of these diseases, substance use disorders and eating disorders. A lot of times that can be nurtured through 12-step programs or other mutual aid programs. And how is that helpful? Why are 12-step programs or mutual aid programs important for creating that idea of hope? Yeah, I'm not alone, and here are some other people who are going through it still or have done it, and they're in recovery, right, for a couple months, a couple years, several years, decades, right? And okay, maybe I can do this. Goes back to unconditional positive regard and respect on part of the clinician as well, right? So do I have a therapist, if I'm the patient, do I have a therapist that I feel has that unconditional positive regard and respect for me? And if I'm the clinician, do I make sure that I have that for my client, even when they frustrate me, even when they don't do my perfect treatment plan that I've laid out for them, right? So do I continue to meet them with that unconditional positivity? And long-term engagement, right? It's not like, hey, thanks for coming to treatment and staying here for 3 weeks, see you never, right? We don't want that. We want long-term engagement with our treatment team through aftercare, through recovery support, through outpatient, whatever it is, follow-ups. long-term engagement with both of these disorders. Services and treatment goals should be client-driven. The more autonomy over treatment level and intensity and goals, the better with SUD and with ED. Especially with eating disorders, studies showed a lot longer engagement with eating disorder treatment if they felt that they got to choose like the level of care that they were signing up for. Right? It goes back to feeling like I'm being respected and heard and listened to when I'm talking to this clinician and they're helping me pick what level of care I need to be at. Do I agree that I need that level of care, and am I willing to do the work that that level of care provides or requires of me? And if I'm not, is my clinician able to still meet me where I'm at, right, and give me something, not say this or nothing? And an integrated treatment team, right, so responsible for engaging individuals and supporting their recovery and connection with a broad range of clinicians outside one's own specialty. So whether I'm an ED clinician or an SUD clinician, I need to have contacts everywhere. I need to have people I can call on when I don't know the answer, because I often will not know the answer. But these are just kind of a broad overview of options for you if you're a person with co-occurring eating disorders and substance use disorders. These are the evidence-based models that, per the people in all these research studies tell me, are the ones that bode the best results. So, and a lot of facilities will hopefully be using kind of a combination of a lot of these, you know, not just one. A lot of places use motivational interviewing to move people towards change and reduce their problematic behavior, right? Sometimes it's harm reduction versus abstinence. This is a lot of meeting people where they're at, motivational interviewing. The stages of change. I've got somebody in contemplation, so what can I do? What can I say to them? What questions can I ask them to move them along into that preparation stage? And likewise, how can I move them into action? Focuses on increasing willingness for the most part and helps people explore that ambivalence that a lot of times they have when they come into treatment. Or I'm here for my substance use treatment, but I'm really ambivalent about getting treatment for my eating disorder, or vice versa. ACT, acceptance and commitment therapy, connection to values. The goal is to develop goals in line with those values. Values and goals drive my behavior, and it hits that self-directedness piece, right? Remember when we talked about personality characteristics of people with co-occurring ED and SUD? They want to be self-directive as much as possible. So developing those goals and actions in line with those goals are going to help that person feel less stuck. CBT gets a ton of hype. It's probably one of the most popular or commonly applied behavioral health model. It's usually relatively short, system-oriented, focuses on changing distorted beliefs, thoughts, values, thought processes. A lot of self-monitoring, problem-solving, coping skills, lots of mindfulness, accountability, that kind of thing. And again, there are so many options here because it's never going to be a one-size-fits-all for you. Never, ever. DBT, if you're familiar with Dawn Farm, you're very familiar with DBT. It focuses on mindfulness, largely skills-based. Also focuses on regulating my emotions, distress tolerance, reducing unhealthy coping, replacing them with healthy coping skills. Good for those disorders of under control, right? Good for that binge eating disorder, the substance use disorders, people with like borderline personality disorder, things where people need a lot of help regulating those emotions, right? I need a lot of help getting to that wise mind area so that I'm making effective decisions. RODBT, radically open DBT is newer to me. Radically open DBT targets disorders of over-control, right? So it's kind of the flip side. Those disorders of over-control, like the anorexia nervosa, people with OCD, some degrees of the autism spectrum disorder, basically helps reduce behaviors centered around control, perfectionism, and rigidity. It uses mindfulness to observe thoughts and unpleasant sensations and emotions with a detached lens, which is basically urge surfing, to acknowledge and allow those feelings to pass. So the Maudsley approach is not a co-occurring approach. It's primarily for eating disorders and for adolescents. It's supposed to be the most effective, or one of the most effective, ED treatment models for adolescents. Parents are heavily involved, a lot of focus on refeeding and return to normal eating patterns. It's a phased treatment where, when you start out, parents or supports pretty much have all control over what that person is eating. And then throughout the phases, phase 2, phase 3, control slowly gets given back to the adolescent, and then they are allowed to choose what they eat. And it focuses on kind of like all of that stuff first, and then secondary explores, the real root causes of they call it the secondary issues related to the ED. Mindfulness-based approaches. Mindfulness is another one of those buzzwords that's getting a lot of hype lately, as it should. Mindfulness is great, right? So mindfulness can and probably should be added to any existing treatment program, right? Even if whatever therapy you're getting right now, if it doesn't have a mindfulness component, add your own mindfulness component, right? Start practicing it in whatever ways you can. These three, this mindfulness-based stress reduction, mindfulness-based TCs, and mindfulness-oriented recovery enhancement are all just like specific programs that some places will use. Like the MORE is like a 10-session program. This is like an actual long-term residential program. And then the mindfulness-based stress reduction is a formal meditation teaching. But there are also programs like DBT and ACT which have the mindfulness component built into them. Because mindfulness is always going to be helpful in recovery from SUD, for ED, and for general well-being. So it's going to be something that's going to carry you throughout the maintenance of these diseases as well. And it can be done through, like, if I'm a clinician and I don't know how to add a mindfulness component to my program or my LU or whatever I'm doing, I can do it with meditations, right? I can start introducing my clients to meditations and breathing exercises and grounding techniques. I was just reading something earlier today that was talking about yoga for eating disorders, because it helps you connect with your body in a much more loving and self-soothing and accepting kind of way with the paired breathing, with the paired meditation, and so that can be especially helpful for people with eating disorders. And it also kind of teaches you how to do that urge surfing thing, right? How to stay calm and breathe through unpleasant feelings either in my body or in my mind. And that's just a cute little mindful, right? The dog's the happy one there because he's mindful. So essentials for effective treatment and recovery initiation. So I need to be at a place that has the belief that EDs and SUDs are complex but treatable illnesses that affect the brain and behavior and do not indicate some kind of moral weakness, right? And also the belief that no single treatment method is appropriate for all individuals. If you come in to my agency and you don't fit neatly within this box, well then I can't help you, right? No. I need to be able to pull out as many tricks and stops as I can, because what's going to work for you is not going to work for you. Treatment as readily available as possible when that window of willingness occurs, right? Because people with eating disorders and substance use disorders are often reluctant to seek treatment, at least at first. So when I finally do have that window of opportunity and I'm willing to do this, I have the hope, I want to try, but I run into so many walls, right? I run into so many wait lists, I run into so many people sending me so many places and talking to all these people on these phones, and then I get frustrated and then I just hang up and say maybe next time, right? So as clinicians and as agencies trying to find a way to get these people engaged immediately, right? If I can't give you an inpatient treatment bed right now, well, I can get you in here, get you in face-to-face. I can get you assessed. Let's get you in a group. Let's, refer you to some 12-step groups. Let's start talking about this at least. Let's initiate some treatment and some recovery while we wait for maybe what our more ideal plan is. Must address the whole individual and his or her multiple needs rather than just the ED or the SUD behavior, right? We're not just trying to eliminate a behavior here. That's a goal, right? A main one. But for long-term stable recovery, I'm going to need to address all of the stuff that's laying beneath that, right? All of the things that led up to that, and all of the things that I'm facing right now. If I'm homeless, that's a huge issue for me too, right? I might be in treatment for a couple weeks for my eating disorder or my substance use disorder, but if I don't have any aftercare plan or anything, and we're not addressing the part where, hey, I'm homeless in the community, and then I leave, all my treatment usually goes out the window because I'm back into survival mode. Adequate length, intensity, and quality of treatment, right? So is the treatment that I'm getting long enough, more than just a few days? Is it intense enough? And is it with a quality team? A team that has that unconditional positive regard for me, respect, I feel safe there, and I'm getting the best kind of evidence-based treatment I can be getting. Support and intervention for families or friends, right? Because families and friends can be really, really key to recovery maintenance. They can also be super detrimental to it, right? If we don't get them engaged quick or kind of notice the behaviors that are not conducive to what we're trying to do here, then they can be a detriment, but we want them to be a support. So if we can get them involved and intervene with family and friends, that's the best way to go. Individual and group counseling and other behavior therapies, right? Just because of that, not one thing fits all. So I've got a lot of different stuff I can throw at you, right? Let's be flexible. Go back to the drawing board if something doesn't work. And nutritional didactics. So like even if I'm at a substance use facility, is there a way that I can have a nutritionalist or a dietitian come in, and give kind of a, a 101 or something on nutrition? Detox and stabilization are those first essential stages of recovery, but they are not enough to maintain long-term stable recovery, right? That's been kind of the theme throughout this whole talk. You guys have probably heard me say that a million times because they are super important, that initial stabilization, that first week, that first month, but the real work starts after that, right? The real work starts, if you're in a 30-day program, the real work starts on day 31, right? What am I doing then? So they are just the beginning stages of recovery, and we need to make sure that people have aftercare plans and people have a supportive network around them to help them. If I'm in treatment for either one, both of my ED behaviors and my alcohol and drug use need to be monitored continuously throughout treatment. Right, so that's the, I'm in substance use disorder treatment, so they're drug testing me all the time, they're breathalyzing me all the time, but nobody's asked me about my, nobody's asked me if I've binged or purged in the last couple of weeks, right, or vice versa. They keep asking me about my eating, but they didn't ask about the glass of wine I drank last night or anything. So making sure that there's continuous monitoring for both of these behaviors throughout treatment, and making sure that clients at either of these treatment centers are being tested for HIV, AIDS, Hep B and C, other infectious diseases or medical issues associated with either disease, and given targeted risk reduction counseling. So does the opioid user in the ED treatment and the SUD treatment get informed consent? Know about overdoses, know about Narcan, know about all of their options. And medical risks for people with AN and BN behaviors. Do they even know what the risk of whatever compensatory behaviors that they're doing? Do they know what's going on in their body? Have they had blood work lately? They might not know that their liver is starting to shut down. Self-help and mutual aid groups, right? So I'm not going to spend a lot of time on this because you guys have it all on your slides, and I think Jess made them big enough so you guys could see them, so that's good. AA, NA, OA is a big one, especially around here. Eating Disorder Anonymous, Anorexics and Bulimics Anonymous. The only thing I'll add there is anybody can go there. You don't have to be an anorexic or bulimic to go there. Anybody who struggles with disordered eating, binge eating, excessive exercises can go there. Smart recovery, if you view your eating disorder as some sort of behavioral addiction, and you certainly probably view your substance use disorder as an addiction, smart recovery might be for you. It's completely non-12-step, very kind of CBT type based, building and maintaining motivation, coping with urges. Refuge recovery, that is getting a lot of traction around here as well. It's a Buddhist path to recovery. And again, they kind of, anybody in recovery from any kind of addiction is welcome there. Celebrate recovery, Life Ring. Point here is that recovery is not rare, recovery is not random, right? It's absolutely possible for everybody. It's just, you gotta be willing to go back to the drawing board a lot of the time. There's at least, if not more, 23 million Americans living in recovery from their substance use disorder. And I don't do math because I'm a social worker, but about 60% of 30 million people with an eating disorder are in recovery and achieve stable, long-term, full recovery. So what we know is that it's doable, right? And that the two key most important things here are going to be early intervention, right? So doing something about it the minute that it's noticed, right? Saying something, trying to get help, and that social support piece, right? The major importance of support and 12-step involvement after treatment, extremely important for substance use disorders, and sometimes not thought of as much for eating disorders for some reason, right? Even though for eating disorders, I still need that accountability. I still need that constant, reminder that I have this disease, right? That is kind of lurking or lying dormant right now because I'm treating it, But if I stop treating it, right, or I lose those social supports, or I don't have accountability anymore, old behaviors can start to crop back up. And I don't want to go back to having to play that whack-a-mole game. I think I only have a few slides left. Oh yes, these are all my resource slides. You see how many words I can put on a slide? A lot. These are just a bunch of local resources in the area. These first 3 are for eating disorders. Here at St. Joe's, they have an excellent adolescent program, Michigan Medicine. Of course, Dawn Farm, Home of New Vision for the substance use disorders. More resources for here, right, how to find all those meetings. Or the eating disorders helpline is super helpful. You can call them, you give them your like zip code, you know, what you're looking for. They'll pretty much tell you like every meeting in the area and what kinds of meetings or what kinds of local resources are available to you. They can help look up your insurance and tell you like what kinds of things you're eligible for. And they're also really supportive. They'll just talk to you if that's what you need. Suicide hotline, oh gosh, mic'd up, is also important, right? Because a lot of people with anorexia nervosa, eating disorders, and substance use disorders report a lot of self-injurious behaviors or suicide attempts. Check out these cool books. These are a lot of the books that helped me when I was kind of curating this whole thing, especially that Making Peace with Your Plate with Robin Cruz and Espra Andras, and these 2 Jenny Schaefer books, Life Without Ed and Goodbye Ed, Hello Me. They pretty much detail her whole treatment, and like I know at least in the second book, The Life Without Ed, it's co-written with her therapist, and her therapist writes chapters in it as well. All right. All right, do you guys have any questions that I may or may not be able to answer for you? So non-binary, meaning that I don't necessarily identify with either gender, right? Or I might be gender fluid. I just don't identify maybe with male or female on any given day. Yeah? She's asking if the resources on this page are for adolescents or for adults. So the Center for Eating Disorders, from what I gathered from them, they treat adults as well and can refer you to adult treatment as well. And they do their hunger-wise and body-wise specialty groups are adult-friendly. The St. Joseph Hospital, the one here, the partial hospitalization program, is for adolescents 12 to 18, and I could not find adult treatment through them. But the Michigan Medicine Comprehensive Eating Disorders have an adult program. They offer all of that for adults, the PHP, the IOP, outpatient, inpatient psych, all of that. Yeah. It depends on what they're there for, right? If they're just there for weight restoration, it can be anywhere from like 2 weeks to like 6 weeks, 2 to 6 weeks-ish, depends on how much weight needs to be restored. If it's a full inpatient residential program, I mean, we're talking 60, 90, 120 days sometimes. Yeah, 6 months even. There are some extremely long-term. Yeah, basically, if I'm in the hospital and I need refeeding, you know, and I'm malnourished, I'm often on feeding tubes, right? So I'm on feeding tubes until I'm able to eat. And it depends on my willingness, right? Like maybe I'm in this hospital and like I'm being kind of combative, right? Like I don't want to eat what they're telling me to eat. You know, I don't want to take what they're telling me to take. They're having to give me feeding tubes to give me my nutrients, so I'm probably not making progress as quickly as I could be, and I'm in that bed for even longer. Yeah. So how does OCD play into the whole scheme of eating disorders and substance use disorders? So OCD sometimes co-occurs with these, sometimes doesn't. If somebody has OCD, they probably already have a propensity towards ritualistic behaviors. Right, strong control, right? I have a big control issue. I need to control everything around me. You know, that might be in the form of, you know, touching things or washing hands or, you know, certain acts or things that I do with daily activities, but it could also go over into the way I eat, the food I eat, how I eat it, when I can eat it. So yeah, somebody with OCD tendencies and co-occurring substance use or eating disorders probably has that over control piece where something like RO-DBT or something would be helpful. But I don't know enough on OCD to say more on that. Right, so for emotion regulation, I would probably recommend like distress tolerance skills, right? Things that I can do to get through whatever stressful emotion that I'm feeling, right? If I'm feeling particularly sad or guilty or whatever feeling is triggering me to want to act out on this eating disorder behavior, DBT, distress tolerance in particular, can help me create that pause, right? It's usually something that I do to distract myself. Something that might be particularly good for somebody with an eating disorder is something that has to do with physical sensation. So can I hold an ice cube for a really long time, or can I use some sort of smells or essential oils, or taste might not be a good one for somebody with an eating disorder, but yeah, some sort of distraction or distress tolerance probably. Oh, okay, so yeah, he's asking about the intermittent fasting. I guess so I will say first and foremost, I don't know a whole lot on it. It's not something I usually do. Right. So if I'm a person who has never really had a disordered eating problem, right, never really had those kinds of ED issues, then intermittent fasting is probably going to be just fine for me, right? It's probably going to be okay. But if I'm a person who even used to maybe have a little bit of OSFED stuff going on, right, some disordered eating, maybe not a full-blown disorder, but I've always kind of been obsessed with, my weight or my body image or my diet. That's where you might start to get into murky territory using something like that. Probably not something I would recommend for somebody with any history of ED. Yeah, so I think she's asking about treatment availability and what do I do if I don't have insurance or my insurance doesn't cover it. Right. Most insurances will have some sort of coverage for substance use under like mental health. Usually, and it really depends plan to plan whether, what kinds of ED treatment they're willing to give you. It's usually, if they are willing to fund it, it's usually outpatient or partial hospitalization. I know that Medicaid is pretty good about funding at least, outpatient or PHP stuff, partial hospitalization for it. As far as that inpatient treatment stay, right, if I need inpatient for an eating disorder, it might be really tough, right? I might have to ask family for resources. I might have to ask about scholarships, right? I know a lot of substance use treatment centers do scholarships. Maybe eating disorder treatment centers do them as well. As far as substance use disorders, I know in Michigan, everybody has a funding source. So no matter what county I live in, I have a funding source, whether I have Medicaid or no insurance. If I don't have private insurance, I can call a number in the county, and they will basically assess me or help me get to somewhere that will assess me, and they'll tell me where they're willing to fund me for treatment. So every county in Michigan does have a funding source. And if you need help figuring out what that is, you can call the intake team at Dawn Farm. We'll tell you all about it. Yeah. For eating disorders, so there are a couple, there's a female-only one called Timberline Knowles, and that's in, forgive me, Indiana or Illinois, starts with an I. Yeah. And they treat they don't just treat eating disorders, they treat like trauma, substance use disorders. Mostly out of the state. I don't know of any inpatient treatment facilities other than, U of M offers an inpatient medical and psychiatric hospitalization, but I don't know how long-term that is. I don't know of any in Michigan. Thank you. And yes.